time for some thoracic trauma and respiratory emergencies. Right up some of y'all's alleys. All right, look at that picture. What the world has happened? So when you look at this picture, what do you see? In this picture, I see an arrow, what looks like to me an arrow, going through the chest wall. And I see it on the left side, what looks like to be in the intercostal space, but I'm not really sure. So it involves the diaphragm, some ribs, I wonder what organs. So as you see on here, it says adapted from Mrs. Cowan, Mrs. Guyton, Ms. Kofke, and now myself. So let's talk about some thoracic trauma and respiratory emergencies. First, let's discuss about oxygen transport, respiration, ventilation, diffusion, and perfusion. So when we talk about pulmonary diffusion, we talk about exchange of gas molecules, oxygen and carbon dioxide, from areas of a higher concentration to areas of a lower concentration. Pulmonary perfusion is blood flow through the pulmonary vasculature. Ventilation is movement of air in and out of the airways, as you see it there in the picture. Respiration is gas exchange between atmospheric air and the blood and between the blood and cells of the body. So we're breathing in and out and we're exchanging carbon dioxide and oxygen. The respiratory system performs functions by facilitating life-sustaining processes. So I bet that fella in the previous picture had some life-threatening issues. When we talk about life-sustaining processes, we're talking about oxygen transport, respiration, ventilation, and gas exchange. Oxygen transport supplies oxygen and removes carbon dioxide from cells by the way of circulating blood through thin walls of the capillaries. Remember in the previous video that I had done for you, I showed you the capillary beds where oxygen and carbon dioxide are exchanged. Oxygen diffuses from the capillaries through the capillary wall to the interstitial fluid. At this point, it diffuses through a membrane of tissue cells where it is used by the mitochondria for cellular respiration. And the movement of carbon dioxide occurs by diffusion in the opposite direction from the cell to the blood, moving in and out. Respiration, after all this tissue capillary exchanges, blood enters the systemic venous circulation and travels to the pulmonary circulation. The oxygen concentration in the blood within the capillaries of the lungs is lower than that of the lungs alveoli. Because of this concentration gradient, oxygen diffuses from the alveoli to the blood. Carbon dioxide, which has a higher concentration in the blood than in the alveoli, diffuses from the blood into the alveoli. Movement of air in and out of the airways continuously replenishes the oxygen and removes the carbon dioxide from the airways and the lungs. This whole process of gas exchange between atmospheric air and the blood and between the blood and cells of the body is called respiration. Lots to think about with all of these words. Ventilation requires movement of the walls of the thoracic cage. And of its floor, ribs, and diaphragm. The effect of these movements is alternating to increase and decrease the capacity of the chest. When the capacity of the chest is increased, air enters through the trachea, inspiration, and moves into the bronchi, bronchioles, and alveoli, and inflates the lungs. Chest rise and fall. When the chest wall and the diaphragm return to their previous position, expiration, the lungs recoil and force the air out through the bronchi and the trachea. Inspiration occurs during the first third of the respiratory cycle. Expiration occurs during the latter 2/3. The inspiratory phase of respiration normally requires energy. The expiratory phase is normally passive, requiring very little energy. Physical factors that govern airflow in and out of the lungs are collectively referred to as the mechanics of ventilation and include air pressure, variances, resistance to airflow, and lung compliance. So when you have your opportunity, Ms. Kofke has already taught you most of these things, but when you have your opportunity to come to critical care at the Mitchell Community College, you'll learn more about those terms: air compliance, air pressure gradients, resistance to airflow, and lung compliance. Pulmonary diffusion and perfusion. Diffusion is when the process by which oxygen and carbon dioxide are exchanged from areas of a higher concentration to areas of lower concentration at the air-blood interface, capillary beds. The alveolar capillary membrane is ideal for diffusion because of its thinness and large surface area. In the normal healthy adult, oxygen and carbon dioxide travel across the alveolar capillary membrane without difficulty as a result of differences in gas concentrations in the alveoli and capillaries. I'm going to include these notes on your PowerPoint slide from this definitions. Pulmonary perfusion is the actual blood flow through the pulmonary vasculature. The blood is pumped into the lungs by the right ventricle through the pulmonary artery. We just talked about that in pulmonary hypertension. The pulmonary artery divides into right and left branches to supply both lungs, the right and left lung. Normally, about 2% of the blood pumped by the right ventricle does not perfuse the alveolar capillaries. This shunted blood drains into the left side of the heart without participating in alveolar gas exchange. Bronchial arteries extending from the thoracic aorta also support perfusion, but do not participate in gas exchange. This comes from your book. Further diluting oxygenated blood exiting through the pulmonary vein. Ventilation and perfusion. Ms. Kofke has taught you that. So let's end in balance. Adequate gas exchange depends on an adequate ventilation perfusion. You'll see that as the VQ ratio. In different areas of the lungs, the ventilation perfusion ratios vary. Airway blockages, local changes in compliance, and gravity may alter ventilation. Alterations in perfusion may occur with a change in the pulmonary artery pressure, alveolar pressure, or gravity. VQ, ventilation perfusion, imbalances occur as a result of inadequate ventilation, inadequate perfusion, or both. As I said, that's a lot of definitions. Come straight from your book, and I will include the notes on your PowerPoint, this slide. Lots pathophysiologically to remember. Thoracic cavity, we looked at some pictures when we did pulmonary hypertension. So this is just a review, these two slides. Thoracic injuries account for 21% of the traumas recorded in the National Trauma Database. Thoracic trauma accounts for 20 to 25% of trauma-related deaths. Makes me think of the person that we saw in the very first PowerPoint slide, that arrow going through and through the left lung. Did it nick the heart? Did it go through the heart? Where did it go? We know that it pierced the diaphragm. So the diaphragm would be this muscle right here that helps inspiration and expiration. So we talked about the heart, the inferior, superior vena cavas, the other vessels that are important in the upper chest, pulmonary trunk, the right and left lungs. So we're going to talk about different anatomical positions, because thoracic trauma, when we talk about those in the respiratory emergencies, it'll help us remember what we're looking at. So anatomy is very important to know which organs may be involved. So the body holds up to 5 liters of blood. Some people hold a little less, a little more. Thoracic cavity can hold 4 liters. That's over half, maybe 3/4 of the volume in the thoracic cavity. So in the thoracic trauma, blunt force trauma versus penetrating trauma. So the first picture was penetrating trauma. So blunt trauma, sudden compression or positive pressure inflicted upon the chest. So a bump from a steering wheel, motor vehicle accidents, a seatbelt pulled tightly against the chest, and even falls can be blunt force trauma. Other types of injuries to the chest, we have chest wall fractures, barotrauma causing ruptures, and injury to the pleura, lungs, heart, and great vessels that anatomically we just looked at. So more common than penetrating trauma is the blunt force trauma, and most often caused by motor vehicle accidents. You got your steering wheels we talked about and your seat belts. Types of injuries: chest walls, chest wall fractures, barotrauma. We talk about that when we talk about ventilators, and other injuries to the chest wall itself. Penetrating traumas occur when a foreign object penetrates the chest wall. The arrow from the first picture. Gunshot wounds, stabbings, fall onto something that's going to penetrate the chest wall. Anything that penetrates the chest wall is considered a penetrating trauma. Types of injuries that these penetrating traumas can cause are pneumothoraxes, hemothoraxes, and or pneumohemos, and cardiac tamponade. Interesting story. I had a young fella, early 20s, in critical care once. Very fit, very stout young man, physically fit. His girlfriend got mad at him and she stabbed him with a chucking knife. And when I say chucking knife, that's one of those big knives with a blade, and nicked his left ventricle. Not opening all layers, but just the outer 2. And he ended up slouching over and tamponading the injury and clotted off, so he did not bleed out on scene. Neither did he when he was in critical care, but he's short of breath because he also got his lung nicked and ended up with a chest tube. Very interesting cases, very interesting things that happen in thoracic traumas and respiratory emergencies. Traumatic pathological states: hypoxemia, hypovolemia, and cardiac failure, resulting in impaired VQ, ventilation perfusion ratio, acute kidney injury, hypovolemic shock state, and even death. Injuries to the chest are often life-threatening and result in one or more of the following pathological states: hypoxemia, from a disruption of the airway, injury to the lung parenchyma, rib cage, and respiratory musculature, massive hemorrhages, collapsed lung, and pneumothorax. So they don't have enough oxygen. Hypovolemia, not enough volume for massive fluid loss from the great vessels, large vessels, including the heart in the thoracic area, cardiac rupture, or hemothorax. Stories to tell. Another young gentleman came in from the jail, had a pocket full of crack rocks. He decided instead of getting arrested with evidence, he was going to pop all rocks in his pocket, and he ended up having a cardiac rupture of the left ventricle, and he bled out. Interesting. Cardiac failure from cardiac tamponade. Zoid took you through that. Cardiac contusions and or increased intrathoracic pressure on a ventilator for PEEP, long periods of time. We got that intrathoracic pressure increase. These pathological states frequently result in an impaired ventilation perfusion, as I will future call it, VQ, leading to acute kidney injury, hypovolemic shock, and then leading to death. Assessment. What does nursing need to do? You ER nurses, here you are. Time and mechanism of injury. We need to know what time this event happened and the mechanism of injury, what caused it to happen. Because time is critical in treating folks with chest trauma, the patient must be assessed immediately to determine the following: time elapsed since the injury occurred, mechanism of injury, level of responsiveness, specific injuries, estimated blood loss, recent drug or alcohol use, and pre-hospital treatment. What did we do before they came to the hospital? So we're going to initially assess the thoracic injuries, including assessment of the airway. Was it obstructed? Do we have a tension pneumothorax, an open pneumothorax, massive hemothorax, flail chest, and or cardiac tamponade? Now, when I say tension pneumothorax, we're going to talk about what that is here in just a little bit, so don't feel lost yet. When I talk about an open pneumothorax, we're going to include that as well, and a hemothorax. A secondary assessment is going to be an assessment of simple pneumothorax, hemothorax, pulmonary contusion or bruises, traumatic aortic rupture, tracheobronchial disruption, esophageal perforation, traumatic diaphragmatic injury, think of the felon in the first slide, and penetrating wounds to the mediastinum. Although listed as secondary, these injuries can also be life-threatening. Initial assessment, secondary assessment, physical exam. You got to get them what we call trauma naked to look at their body. Includes inspection of the airway, thorax, neck veins, and breathing difficulties, airway, breathing, circulation. If we see these things in our assessment, the rate, and we're going to include the rate and the depth of breathing for any abnormalities, as stridor, cyanosis, nasal flaring, and the use of accessory muscles, drooling, and overt trauma to the face, mouth, or neck. So we're thinking of it as the upper portion. The chest is assessed for symmetrical movement, symmetry of breath sounds, open chest wounds, entrance or exit wounds, impaled objects, tracheal shift, distended neck veins, subcutaneous emphysema, and paradoxal chest wall movement. We're going to go into what those things are in this presentation. The chest wall itself is assessed for bruising, petechiae, lacerations or burns, and the vital signs and skin color are assessed for signs of shock. So we had signs of shock, hypovolemia we talked about. We would see a low blood pressure and a high heart rate at first, and then we're going to lose both. The chest wall, I just said, was going to be assessed for bruising, petechiae, lacerations or burns, and vital signs during this time will be assessed. We're going down the body, head to toe. The thorax is palpated for tenderness or crepitus. Crepitus is that subcutaneous emphysema, air moving underneath the skin, and the position of the trachea is also assessed. So when we put our fingers and our hands, our gloved hands on this person, you got to rock them a little bit gently, some not so gently, so that you can tell if things are where they're supposed to be normally. Remember, Ms. McCarg has always preached, you have to know normal before abnormal. The initial diagnostic workup includes a chest x-ray, a CT scan, complete blood count, clotting studies, type and cross match, electrolytes, oxygen sat, arterial blood gases, and the EKG. So when we do this initial workup on these folks, chest x-ray can tell us if we've got blood in the lungs or collapsed lungs. CT scan can tell us anything more about penetrating injuries, so we can see what is damaged or if we have a collection of blood or extra air somewhere. CBC is going to tell us about our blood count, hemoglobin, hematocrit, and our clotting studies, our platelets and other studies. Type and cross match, we may need some trauma blood, which is O negative, electrolytes, oxygen sats, and arterial blood. Now, in a situation like this, when you're assessing a trauma patient, you are not by yourself. You are with a trauma team in the emergency room. Ongoing assessment constantly is so essential to monitor the patient's response to any treatment, reassess, and to detect early signs of clinical deterioration. Always, anytime you do something to a critical patient, any patient, always reassess to make sure that they're going to have a good response or any response to what you just did, the treatment, and detect any early signs of clinical deterioration. You weren't an off evil things. So when we talk about the physical exam, level of responsiveness is perfusion and oxygenation. Are they perfusing enough blood to the brain with oxygen so the patient can talk to you if they're able to? Neck veins, arteries, trachea, midline, and muscles. Breathing, depth, rate, ease, or difficulty. Accessory muscles, are they working really hard? Are they able to breathe normally? Probably not with thoracic trauma. Do they have stridor, cyanosis, nasal flaring, or symmetry? Overt trauma for these folks to the face, mouth, neck. Any protruding objects going through their chest. The other wounds, cuts, burns, bruising, or swelling. So you are looking for things that can cause other injuries. Palpate that chest for tenderness and crepitus, air moving under the skin. Some folks say that it feels like if you were to put your hand on the skin and roll your hand as you go up or down, you can feel the air move like Rice Krispies sound in a bowl popping. So chest, remember, symmetrical rise and fall, lung sounds equal, are they absent? Lots to do in an assessment. How are we going to manage these folks? The goal of management is to evaluate the condition and treat the word aggressively to restore oxygen and help with perfusion. We need to establish an airway and oxygen support. If they need to be intubated and put on the ventilator to protect the airway, then we need to do that. We need to reestablish fluid volume, 2 large bore IVs on the way in. And just remember this statement that Ms. McClark says, replace the blood with blood. So also stabilizing the chest wall and organ integrity. And you get your vital signs. And we talked about pulse ox and some other things that you do when you get your vital signs. And we talked about labs, CBC, chest x-ray, CT, clotting studies, type and cross match, chemistries, and ABGs. So reestablishing, I'm going to jump back there for a sec. Fluid volume is these folks are, when they have thoracic trauma, you can put them into respiratory emergencies. Excuse me, they're at high risk for sanguinating, bleeding out, and blood loss. So crystalloids, normal saline and LR, colloids, blood, replace blood with blood. Stabilizing that chest wall and organ integrity, remove the air where it's not supposed to be, or fluid that doesn't belong there, get rid of it. So you need to monitor eyes and nose, and what you're taking out, you need to replace. Got some pictures. Subcutaneous emphysema. I don't know how many of you have felt subcutaneous emphysema, but this occurs when the air gets out into the tissues under the skin. Most often occurs in the skin covering the chest wall or neck, but can also occur in other parts of the body. I've seen it crawl up the side of the ear, behind the neck. I've seen it crawl up on the forehead, behind the eye, and also to the tip top of the head. Now, in this picture, I want you to notice the fellow on the left. I see a clavicle on the right, but I don't see a definitive clavicle on the left side. I see chest in itself is protruding more asymmetrically. I would use that term. And I would be interested to know if he has some subcutaneous emphysema there. This little fella on the right side, it's got some subcutaneous epi in the shoulder, and also has moved up the side of his neck into his jaw. Bless him. No matter what kind of the chest trauma a patient has, when the lung or the air passages are injured, air may enter the tissue planes and pass for some distance under the skin. As I said, I've seen it move up behind the eyeball to the forehead, and I'm sure other people that have worked out in the field with trauma and either in the ER as well have seen it in other places. Tissue gives a crackling sensation when it's palpated. You know, what Rice Krispies sounds like in the bowl, that's what it feels like when you palpate it. Subcutaneous air produces an alarming appearance to the face, neck, body, and also down to the scrotal area. Subcutaneous emphysema is of itself usually not a serious complication, but the subcutaneous air can be absorbed over time. In severe cases, it is widespread. A tracheotomy may need to be performed to protect the airway. We need to think about that airway. Sad pictures there. Pulmonary contusions. What's a contusion? A contusion is a bruise, a bad bruise. Pulmonary contusions occur with most blunt chest traumas. Injury to the lung tissue itself. It collects blood around the tissue where the contusion is. We're going to talk about some signs and symptoms, treatment priorities, maintaining that airway, and adequate oxygenation and pain control. Remember when most recently, it's been a while now, but most recently we give pain medicines on a pain scale of mild, moderate to severe. And think about how you're going to treat those. Pulmonary contusions may not be evident initially on exam, but develop in post-traumatic time, the period of time after the injury. It may involve a small portion of one lung or a massive section of a whole lung, one entire lung, or sometimes both lungs. Your motor vehicle accidents, popping the steering wheel, or the seatbelt snagging their chest, depending on the extent of injury, this type of trauma may be associated with a mortality rate greater than 50%. These folks have a hard time breathing. So pathophysiologically, injury to the lung parenchyma, lung involved, that part of the lung is involved in the gas transfer, the alveolar ducts, and the respiratory bronchioles. and its capillary network. Fluid collects, blood, edema, cellular debris, and enter the lung and accumulate in the bronchioles and the alveoli, where they interfere with gas exchange. Remember, if we can't exchange the carbon dioxide, we're not breathing very well at all. An increase in pulmonary vascular resistance and pulmonary artery pressures will occur. The patient has or can become hypoxic and also retain carbon dioxide. What are we going to see in these folks? Pulmonary contusions may be mild, moderate, or severe. Clinical manifestations can vary. Decreased breath sounds on the area of injury. Tachypnea, I'm having a hard time breathing, so I'm going to breathe faster. Tachycardia, I'm injured, I'm nervous, and I'm scared, so my heart rate's going to go up. I'm going to have chest pain where I popped the steering wheel or my seatbelt kept me tight. And hypoxemia because my gas cannot exchange or I've had an injury to the lung parenchyma. Blood-tinged secretions to more severe tachypnea, tachycardia, crackles, flank bleeding, severe hypoxemia, cyanosis, and respiratory acidosis can occur with these folks. So you have to watch all these labs that you're fixing to get. Changes in sensorium, including increased agitation or combative irrational behavior, may be early signs, can even be latent signs of hypoxemia. When somebody can't breathe, they're going to fight you, or they're going to be agitated, extremely agitated. Moderate pulmonary contusions are large amounts of mucus, serum, and or frank blood in the tracheobronchial tree. Patients often have a constant cough, but cannot clear their secretions. Severe pulmonary contusions are central cyanosis, the core, agitation, combativeness, and productive cough with frothy, bloody secretions. So when we assess these folks and diagnostic findings, I bet you a CT is going to be in order, chest x-ray are going to be in order, and the efficacy of gas exchange is determined by pulse ox. If my pulse ox is low, then I'm not oxygenating. My arterial blood gases are going to measure what my PaO2 and PCO2 is going to be. The initial chest x-ray may show no changes and may not appear for 1 or 2 days after the injury and appear as pulmonary infiltrates on a chest x-ray, so warranting CTs and other studies. We're going to medically manage these folks. Mild pulmonary contusions are going to get some supplemental oxygen depending on what their O2 sats is. And usually it's by a mask or a cannula for 24 to 36 hours. We're going to give them some adequate hydration with IV fluids. Remember we talked about the normal saline or the LR and the colloids of the blood. Oral intake is important to mobilize secretions and avoiding overhydration and hypervolemia. We don't want to flood them. Coughing and endotracheal suctioning are used to remove secretions. Pain is managed by intercostal nerve blocks or by opioids via PCAs. So if I have some fractured ribs, which we'll get there, and we talk about fractured ribs, nerve blocks, intercostal nerve blocks are very, very important for these folks so they can breathe. Usually, antimicrobial therapy is given because the damaged lung is susceptible to infection. The body realizes that something's going on that's not supposed to be. So remember back when we talked about inflammatory responses. Moderate pulmonary contusions, bronchoscopies may be required to remove secretions because the patient's not able to cough them out. Intubation and mechanical ventilation with PEEP may also be necessary to maintain the pressure in their lungs and keep the lungs inflated. Severe contusions may develop respiratory failure. So we got to protect that airway. Aggressive treatment with endotracheal intubation and ventilatory support. Diuretics and fluid restrictions may be necessary. We don't want to flood them with a lot of fluid Antimicrobial medications may be prescribed for the treatment of pulmonary infection. This is a common complication of pulmonary contusions, especially they get pneumonia in that contused area because the fluid in the blood that has extravagated into that area of the alveolar or interstitial spaces serve as a wonderful, excellent culture medium. Think about doing a microbiology when you did the petri dish. What's inside that petri dish is blood. So organisms love to grow in blood. Pneumothorax, we mentioned that earlier. PTX, collapsed lung, a simple traumatic or a tension pneumothorax, signs and symptoms of both. And then, yes, Ms. McCard has included a video. Actually, the first person that did this included this video. And these videos are worth every second of watching. When you have a pneumothorax, pain is sudden, quick and sudden. They may only have minimal respiratory distress and slight chest discomfort at first, and even tachypnea with small, simple, uncomplicated pneumothorax. If the pneumothorax is large and the lung collapses totally, acute respiratory distress will set in. The patient becomes anxious, they'll fight you, and they have dyspnea and air hunger. They're sucking for air. Has increased use of the accessory muscles. You will see in intercostals, they'll pull in and they'll pull their shoulders up, and you'll see their chest move in different ways. And they may develop central cyanosis and become severe hypoxic from large pneumothoraxes. The video walks you through different kinds of pneumos. It's just a short 2-minute video worth a watch. Simple pneumothorax and spontaneous. A simple pneumothorax is a non-expanding collection of air around the lung. And so on the left, you see a normal lung. On the right, you see what's on the lungs known as blebs or bullae. And air leaks out of these, and eventually on the blebs, they'll pop and cause a spontaneous pneumothorax. And when they rupture, they cause the air leak, the subcutaneous emphysema, and then the air gets into the pleural space, creating pressure on the lung and can cause the lung to collapse. Blebs may be present on individuals' lungs just because they're there pathologically, and they may just all of a sudden rupture. So look for signs and symptoms for these folks that have spontaneous pneumothorax, for them to become dyspneic and watch their breathing. Causes of simple pneumothoraxes or spontaneous may be caused by diffuse interstitial lung disease. Think of your COPD patients and those that you have to use a lot of air when they're on the ventilator and a lot of PEEP. And emphysemas as well. These folks get into trouble very quickly with blebs. Blebs are more common in men, tall men, and skinny. They will happen abruptly, pleuritic type chest pain, dyspnea, shortness of breath, tachypnea, tachycardia, and decreased breath sounds where the blebs have popped. So with the signs and symptoms, you're going to monitor them and watch them. Of course, we're going to let the healthcare provider know, because what can happen is that lung can collapse, which is the lower right side, and we need to get a chest tube and decompress that area so that lung can re-expand. We're going to treat them with some oxygen, observe them, watch them, make sure they don't get worse. We're going to be monitoring them with chest x-rays. Traumatic pneumothorax or an open pneumothorax. A traumatic pneumothorax occurs when air escapes from a laceration in the lung. So you have a penetrating injury that tears open an area. See over in the picture on the left, air is allowed to enter from outside, not the normal way down the trachea and the bronchial tree, but from outside into that lung space, pushing that lung so that it then collapse. It can occur when air escapes from a laceration in the lung itself and enters the pleural space, or from a wound to the chest wall. But the fellow that we saw in the very beginning had this very issue. It may result from blunt trauma, rib fractures. When rib fractures are bad, they can saw together and drop a lung. Penetrating chest or abdominal trauma, stab wounds or gunshot wounds. Diaphragmatic tears. Traumatic pneumothorax may occur during invasive thoracic procedures, such as a thoracentesis, putting in a central line in the subclavian. So that's why you will see anesthesia go up to the jugular vein instead of here in the subclavian. When they go subclavian and they have to go that way, then you have to think about your folks that have like emphysema, their lungs expand greatly and don't deflate all the way. You can puncture a lung. Barotrauma from mechanical ventilation as well. Penetrating injury to the chest wall, often accompanied by hemothorax. Hemothorax is when blood enters that space and collects in the pleural space from a torn intercostal vessel, laceration of great vessels, or a laceration of the lung. Can be from trauma or not from trauma. Sometimes air and blood found in the chest cavity, air and blood together, is known as a hemo pneumothorax after major trauma. Open pneumothoraxes is one form of traumatic pneumothorax. The wound in the chest wall is large enough to allow air to pass freely in and out of the thoracic cavity with each attempted respiration. A rush of air through the wound in the chest wall produces a sucking sound, and the lung collapses. Structures of the mediastinum, the heart and great vessels, also shift toward the uninjured side with each inspiration and in the opposite direction with expiration. This term is known as mediastinal flutter or swing and produces serious circulatory problems. So you see in the picture there where the air moving on the left side, when the air moves in and out, you can cause a shift and you'll see this trachea will move back and forth when the patient's trying to breathe. The severity of the open pneumothorax depends on the rate of thoracic bleeding and the amount of air in the pleural space. The pleural cavity can be decompressed by needle aspiration, thoracentesis, or by a chest tube drainage of the blood and or air. The lung is then able to re-expand and resume the function of gas exchange. The chest wall is opened surgically, thoracotomy, if more than 1,500 milliliters of blood is aspirated initially by the thoracentesis and output in the chest tube, or if the chest tube output continues to be greater than 200 milliliters per hour, we need to replace that fluid. So in this picture, one more time, we talk about the pneumothorax, open and sucking chest wound here. The arrow went through. So we're going to dress the three-sided tape. See the picture on the right so that the air can escape underneath. Chest tube insertion or mediastinal swing, dress three sides taped. Inspiration and expiration, leave it untaped here at the bottom. We got three sides taped. We have the collapsed lung that we're trying to get to open back up, to re-expand. So dressing seals the blocking air entry, trapped air able to exit through the untaped section of the dressing. So signs and symptoms of a tension pneumothorax from a traumatic pneumothorax, and we'll talk about tension pneumothorax. This is a medical emergency. something to remember. And this can happen with an open or a closed chest wall injury. And when we talk about these, tension pneumothorax, when this lung collapses, the pleural space fills up either with air or blood, pushes that lung over here, pushing the heart and the opposite lung away, so then you see tracheal deviation. So here again, some more videos, decompression needle placement and decompression video. So I will say to you, when you are a practicing registered nurse in a facility, nursing, state board of nursing will not allow you to decompress these areas. So with each breath and a tension, a positive pressure is increased within the affected pleural space. Like I said, it collapses, pushes that area, that collapsed lung, the heart, and the other lung, pushes it, it compresses it. All as well as the great vessels and the, as I said, the trachea. To the unaffected side, mediastinal shift. Both respirations and circulatory function are compromised because of the increased intrathoracic pressure. So that makes it a decreased venous return to the heart, causing decreased cardiac output, impaired peripheral circulation. In extreme cases, the pulse may be undetected, and on the monitor, you will see that PEA, pulseless electrical activity, can occur. Clinical picture is one of tachypnea, air hunger, agitation, increasing hypoxemia, central cyanosis, hypotension, tachycardia, profuse diaphoresis. This person becomes terrified. They cannot breathe. Their cardiac output is tanking. They are tanking. When I say tanking, they're circling the drain. When I say circling the drain and tanking, they're becoming sick quickly, and you better work aggressively. Breath sounds will be diminished or even absent. Percussion to this area is hyperresonant because you're hearing air. Mediastinal and trachea, the trachea is shifted away from the affected side, tracheal deviation. Cardiac output and blood pressure will drop dramatically from the increase of interthoracic pressure. PEA can occur. You do not have a pulse, but you do have electrical activity because you still have those electrolytes in your bloodstream that can cause that electrical activity. You've lost your pulse, they're PEA. Treatment immediately, aggressively, give high concentration of supplemental oxygen to treat the hypoxemia, pulse ox to monitor your oxygen sats. An emergency situation can be decompressed by inserting a large bore needle, 14 gauge, at the second intercostal space mid-clavicular line on the affected side. This relieves the pressure and vents the positive pressure to the external environment. The chest tube is then inserted and connected to suction to remove the remaining air and/or fluid. Pneumothorax, air, hemothorax, fluid, blood. And this allows reestablish the negative pressure and re-expansion of the lung. If a prolonged air leak continues, surgery may be necessary to fix the leak. 2 videos. Hemothorax. I told you we were going to talk about all of these. Hemothorax, hemo blood, thorax, chest. Accumulation of blood in the chest wall. A pneumothorax is the left lung picture where there's air in the chest cavity. A hemothorax is blood, and then you have a hemopneumo where you have both. Where blood is instead of air, it's in your hemothorax. Hemothorax is blood instead of air. Results from an injury to the lung costal blood vessels, great vessels, and other structures. May result from a laceration to the liver or the spleen combined with diaphragmatic rupture. Massive hemothorax is a rapid accumulation of 1,500 mLs of blood in the pleural space. Remember earlier we said the chest cavity can hold 4 liters. We're going to assess for anxiety or restlessness, can't breathe, dyspnea or tachypnea, chest pain, signs of shock, tachycardia, cyanosis, diaphoresis, and hypotension, and decreased breath sounds on the affected side. Interventions is to prepare for a chest tube insertion, 2 large bore IVs, large bore for CT, and then you may get a central line as well. Chest tube to drain, let's see, and those chest tubes are 32 French and sometimes smaller, sometimes bigger. So let's talk about let's talk about pneumothorax. So as you watch this, you're going to see the word collapsed. So here's something to look for. Chest pain, sharp and sudden, the worst on inspiration, and they have cyanosis. Overt tachycardia and tachypnea, low blood pressure, low SpO2, your pleth, pulse ox, absent lung sound on the affected side, pushing of trachea to unaffected side is a tension pneumo, subcutaneous emphysema, escaping carbon dioxide, air collecting in the skin, crunchiness, bulging of the skin, and then we have also S for sucking sound with an open pneumothorax. E, expansion of chest rise and fall is unequal, asymmetrical. Dyspnea, so you have the word collapsed. Tension pneumothorax, air enters the pleural space, compresses the lung and shifts the mediastinal, called mediastinal shift. Trachea moves, trachea deviation. So we have decreased breath sounds. What you hear in that side is nothing. And sometimes people will describe it as a slight whisper or hyperresonance sound. Treated with a needle decompression in the second intercostal space at the midclavicular line, followed by a chest tube or a chest thoracostomy. Is the chest tube in yet? Gotta get it done aggressively. Sternal fractures and rib fractures. I said something earlier about rib fractures. Had an elderly lady who fell, and she had ribs 4 through 8, I believe, 4 through 9. And getting her up out of bed was a nightmare. Her pain was unbelievable. So anesthesia came over and put in a nerve block in the intercostal space. And once we got her up to the chair, she was able to reach her arms up, give me a hug, and said, I have not been able to breathe until now. So just think about the things that you can do for these folks. Sternal, sternum, and rib fractures. Rib fractures are very painful, makes it very hard for folks to breathe. You can see here that rib fractures on the left side, I see rib 2, 3, 4, 5, and 6, possibly 7, can't see below that. Sternal fractures are most common in motor vehicle accidents from sternum striking the steering wheel. Most rib fractures, while painful, are not too dangerous and are treated conservatively. But when you have the first 3 broken or 3 in a group, then you need to consider something for pain. The first 3 ribs, when they are broken, you have to think about laceration to the subclavian artery or the vein. Lower ribs associated injuries with spleen and liver. So we're talking lower down when they're fractured. You have to think about the organs around them. So with rib fractures, you can have a risk of pneumonia because folks won't breathe, and they're the elderly population. We're going to assess them: chest pain, tenderness, the quality of pain, bruising, crepitus, clicking noises when we listen, the ribs pulling apart from each other or rubbing each other as the person tries to breathe, swelling, possible chest wall deformities. It's not symmetrical, it's asymmetrical. Severe pain, worse with cough, deep breathing, or movement. These folks are reluctant to move because they can't breathe. So they are set up for atelectasis, pneumonia, and hypoxia. We're going to diagnose their fractures on a chest x-ray. We're going to do an EKG to check their heart. We're going to get some vital signs, monitor their pulse ox, ABG to make sure that there is no impairment of oxygenation. Medical management is going to pain relief, help prevent pneumonia. And they may, as I have said, third time now, may need intercostal nerve blocks. Avoid excessive activities. Getting out of the bed to the chair is a must. Treating any associated injuries. Rarely a surgical fix. Pillow to splint for support and decreased pain. Deep breathe and cough. Pain usually better in 5 to 7 days. Not always. Most fractures heal in 3 to 6 weeks, and we're going to monitor them closely for any associated injuries. Flail chest. Seen flail chest before. These folks, like with all that we've talked about in issues, a respiratory emergency. Blunt chest trauma causes flail chest, often from the steering wheel of the motor vehicle accident. We got some normal breathing video. We got a flail chest video. Oh, y'all need to see these. And then a flail chest 2. And then the last one is the best. Chest music, flail chest music video. Been talking too long. So during inspiration and expiration, you see that the chest is moving asymmetrically. 3 or more adjacent ribs are fractured, or 2 or more sites, resulting in free floating rib segments. Those ribs are just hanging out, not together anymore. This may result in a combination of fractures of ribs and costal cartilages or the sternum. Chest wall loses the stability, causing respiratory impairment and distress. During normal inspiration, your diaphragm pulls down, expanding the chest wall and pulling air into the lungs. Air is pulled in from an area of high pressure to an area of low pressure. In flail chest, the fractures have led to a free floating segment of rib cage, which is not attached to the chest wall. Therefore, on inspiration, the affected areas get sucked inward. This causes the mediastinum to shift toward the unaffected area. In flail chest, the fractures have led to a free floating segment of the rib cage, which is not attached to the chest wall. Therefore, on inspiration, the affected area gets sucked inward. This causes the mediastinum to shift toward the unaffected area. That's important to remember. On expiration, the flail segment bulges outward and the mediastinum structure shifts back towards the affected side. You'll see that in the videos. This is paradoxal. This is a paradoxal action, it's called, meaning it's moving opposite of what it's intended to do. Your lungs should be drawn outward during inspiration and inward with expiration. It is opposite of that in flail chest. It results in an increase of dead space, decrease of alveolar ventilation, usually accompanied by increased secretions and atelectasis can end up in the bases of their lungs. These folks are also needing some help in a bad way. So we need to watch oxygen, carbon dioxide. So what happens next? They become hypoxic, respiratory acidotic. From CO2 retention, they become hypotensive with inadequate perfusion. Metabolic acidosis can occur due to the paradoxical motion of the mediastinum decreasing cardiac output. We're going to put them on a vent so that we can manage their airway in their chest. We're going to help them clear their secretions while they're on the vent and control their pain. If you have a small segment of ribs that are floating around, the objectives are to clear the airway through positioning, coughing, and deep breathing, suctioning to aid the expansion of the lung, and to relieve pain by the intercostal nerve blocks. High thoracic epidural blocks can be used, and use caution with IV opioids. Mild to moderate flail chest injuries. The underlying pulmonary contusion is treated by monitoring fluid intake, appropriate fluid replacement while relieving chest pain, pulmonary physiotherapy, percussion, focusing percussion gently. Most of the beds nowadays can do that. On lung volume expansion and secretion management techniques. The patient is closely monitored for further respiratory compromise. Severe flail chest injuries, these folks need to be endotracheally intubated and put on a vent and are required to provide internal pneumatic stabilization because there is no stability with all these ribs floating around or floating in the area that they were fractured. And that will help them with gas exchange. This helps also to treat the underlying pulmonary contusion, allowing the patient to rest so we can ventilate and perfuse. VQ serves to stabilize the thoracic cage to allow the fractures to heal, improves alveolar ventilation and interthoracic volume by decreasing the work of breathing. The treatment modality requires endotracheal intubation and ventilator support. Different modes on the vent. Ms. Kofke will take you through that lecture. In rare circumstances, surgery may be required to move more quickly to stabilize the flail segment. This may be used for patients who are difficult to ventilate or for patients who are at high risk for underlying lung diseases, who may be difficult to wean from mechanical ventilation. Regardless of the type of treatment, this patient is carefully monitored, extensively monitored in critical care, serial chest x-rays, ABGs, pulse ox, bedside pulmonary function tests can be done and monitored. Pain management is key to successfully treating these folks. Think of PCAs, intercostal nerve blocks, epidural analgesics, and interpleural administration of opioids may be used to relieve and manage thoracic pain. These folks hurt. And again, because we're talking about respiratory emergencies and thoracic traumas, bronchial tree disruptions. We have the main stem bronchus. Go off to the right bronchus and the left. These happen on rare occurrences, but are life-threatening. Surgical intervention is required. Primary initial goal is to stabilize the airway and localize the injury and then determine the extent of injury. Gunshot wounds are the most frequent causes of penetrating tracheal bronchial issues. Blunt trauma is related to motor vehicle accidents, shearing related to deceleration, clothesline type injuries, shearing related to deceleration. So when you're going 70 miles per hour down the highway and then all of a sudden you rear end somebody, your body's still going, but the car stops. Clothesline type of injury. Think of the clothesline that grandma or mom used to use in the backyard. And we used to run around the backyard and then we would hit the clothesline. But this is a bigger clothesline injury. Bronchial tree disruption can be a rupture if pressure inside the bronchial tree increases past the elasticity. When hit, the bronchial tree will rupture. The first most important priority is acute to ensure adequate airway. So the priority for bronchial tree disruption is to ensure adequate airway. Patients with any kind of distress and clinical suspicion of airway injury must be immediately intubated to protect their airway, preferably under the guidance of a flexible scope so they can see any injury as they're intubating. These folks, signs and symptoms they're going to show: dyspnea, respiratory distress. They're going to have hoarseness, dysphonia, subcutaneous emphysema in the neck, face, and upper thorax. Pneumothoraxes can possibly happen. Hemoptysis, blood spitting up, and decreased or absent breath sounds, air liquid leakage from penetrating wound in the neck, and about 60% of these folks from penetrating injury to the cervical, because it's right behind the trachea. We're going to diagnose this bronchial tree disruption with a bronchoscopy, a laryngoscopy where we can look into the larynx down through the bronchus, is a crucial part of seeing where the tear or the disruption may be. Carefully examining the tracheobronchial tree with a fiber optic bronchoscopy provides the provider with the information and the extent of energy. It's been a long extent of injury. So these folks may need a smaller intratracheal tube, or they may need an emergent cricordotomy where you have to have a tracheostomy. So you have to be careful with this person because you don't want them to mess up the tracheobronchial tree any worse. Ruptured diaphragm, potentially life-threatening, results from blunt or penetrating trauma, most common in the motor vehicle accidents. Left side happens more because the right side is protected from a solid liver. Abdominal contents can herniate into the thoracic cavity, compressing the lungs and making it unable for them to breathe, causing respiratory compromise. So when we think about penetrating trauma below the fourth intercostal space, indicates potential for a ruptured diaphragm. So remember the picture that we saw in the very, very beginning. Assessment: are they dyspneic or orthopneic? Do they have dysphagia, abdominal pain, pain in the shoulder, air has escaped up to the shoulder, intraperitoneal bleeding? Bowel sounds need to be auscultated in all lung fields to determine if you have bowel sounds. Decreased breath sounds on the injured side. Interventions is prepare them for surgery. Cardiac tamponade. Beck's Triad. Ms. Guyton will take you more through emergency medicine, but cardiac tamponade is something that you have already talked about. So we have Beck's Triad: distant heart sounds, distended jugular veins, decreased arterial pressure. It is a medical emergency. Cardiac tamponade is a compression of the heart resulting from fluid or blood within the pericardial sac. It is usually caused by blunt or penetrating trauma to the chest. Remember the fellow I told you about. Cardiac tamponade also may follow diagnostic cardiac catheterization. They penetrate through the ventricle when they're going through. Angiographic procedures and pacemaker insertions. which can produce perforations of the heart and great vessels. Pericardial effusions with fluid compressing the heart also may develop from metastatic disease to the pericardium, from malignant tumors of the breast, lung, or mediastinum, and may occur with lymphomas and leukemic patients. Kidney injury, tuberculosis, and high-dose radiation to the chest. Chapter 29 discusses this more in detail for cardiac tamponade. Beck's Triad. Chest pain. These folks are going to complain of chest pain. Beck's Triad is the DDD. Tachycardia. They also can have PEA, dyspnea, cyanosis, pulse paradoxus, a decrease of 10 millimeters of mercury or more in the systolic blood pressure on inspiration. Drownings, submersion injuries. Drowning is the third most common cause of accidental death in the United States. It's defined as either fatal or non-fatal. All people, all ages are at risk. What's the difference between submersion and immersion? Submersion is head and body. Immersion is just the head. Fatal being death. Non-fatal is rescued at some point. No morbidity, no respiratory impairment. Morbidity is respiratory impairment in the non-fatal category. Risk factors. Generalized swimming ability. Overestimating your swimming ability. Gotta love the ocean. You swim too far out. Trauma. Seizure disorders. Don't know when they're going to happen. History of prolonged QT. African American males. And I say this because a lot of people are afraid of the water. Rural area living. And all right, quick pause there. So let's go back to this generalized area and we talk about history of prolonged QT. Prolonged QT, you've learned how to measure the QT interval, the heart rhythm disorder that may cause serious irregular heartbeats, arrhythmias. So you don't know when those are going to happen either. The heart muscle takes longer than normal to recharge between beats, and this electrical disturbance, which often can be seen on an EKG. That's a prolonged QT. You know where to measure it. So when the QT gets longer and longer and longer, they'll stretch out and they'll become no rhythm at all. Cold water prolongs QT intervals and also causes folks to become very bradycardic. In the rural areas, decrease access to swimming areas to know how to swim. They don't get in the water that often. Low income, no money for swim lessons. So age specific, less than 5 have drownings in bathtubs, buckets, and toilets. And the old saying goes that you can drown in a very small amount of water. So these folks are not watched, not supervised, less than 5 years of age, sat in a bathtub. 15 to 25-year-old, risky behaviors, alcohol and drugs. You know, that alcohol gives you some liquid courage. So rivers, lakes, and beaches, water skiing, cliff jumping. And then the elderly is where you're going to see more heart disease causing them to drown. They get out over their head, their swimming ability. They don't realize where they are, and they drown. There's a drowning video on this slide. So pathophysiologically, salt water versus fresh water versus contaminated water, the process of the drowning, types of drowning, and systemic pathologies and complications. A non-fatal drowning is 3 to 4 milliliters per kilogram aspirated. So that could be salt, fresh, or contaminated. And then more than 11 milliliters per kilogram before blood volume changes. So think of salt water, all the sodium, contaminated water, all the contaminants. And then more than 22 milliliters per kilogram before electrolyte changes. When these folks are drowning, they panic. Loss of normal breathing pattern, they have a tendency to hold their breath. They gasp. So then when they have to breathe, the gas becomes an aspiration of water into the hypopharynx. This leads to laryngospasms. The voice box will closes their airway, and they become hypoxic. Dry in this picture, airway stays closed, causing hypoxemia. Wet is inhaled water that interferes with respiratory process. Cannot breathe with fluid in your lungs. Secondary means aspiration of water after vomiting. So there you see the involuntary gas causing the laryngospasms. Is it dry or is it wet? Do I have fluid or do I not? Causing cerebral hypoxia, acidosis, and cardiac arrest, leading to brain injury and brain death. What is in the pulmonary system that is affected when someone sucks in water? Surfactant. Surfactant helps keep alveoli open. And then when you drown, your alveoli collapse, causing atelectasis, no ability to oxygen or carbon dioxide exchange, causing hypoxemia. So these folks are going to have a lot of wheezes and a lot of crackles if they make it a non-fatal drowning. They're going to be coughing, 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 and then coughing. So both saltwater and freshwater wash out surfactant, often producing a non-cardiogenic pulmonary edema and the acute respiratory distress syndrome. Pulmonary insufficiency can develop rapidly. Signs and symptoms include shortness of breath, crackles, and wheezing. The chest X-ray or CT presents with normal to a localized perihilar or diffuse pulmonary edema. Neurologically, when they're hypoxemic, leads to ischemia, leads to neuron damage, leading to cerebral edema, causing their ICPs to become elevated. Early on, their decreased level of consciousness, agitation, and a headache. Cardiovascularly, initially arrhythmias, tachy or brady, followed by the fib rhythms, most often in the brady, PEA, and asystole. You get acid-base and electrolyte imbalances, both with metabolic and respiratory acidosis. And then electrolyte imbalances generally do not occur in the non-fatal drowning survivors, except those submerged in unusual media, meaning contaminated, such as the Dead Sea, high sodium, where the extremely concentrated seawater can produce life-threatening hypernatremia, hypermagnesium, hypercalcemia due to the absorption of the seawater. So renally, because we have a tendency to squeeze and shut down, acute tubular necrosis. Complications, we talked about some of these: hypoxia, hyperthermia, depending on the degree of temperature of water, pneumonia, depending on the degree of amount of water, salt water, fresh and contaminated water, ARDS, cerebral hypoxia, acidosis, respiratory arrest, and cardiac arrest. management of these folks is going to depend on where they are, non-fatal or fatal. So pre-hospital CPR, respiratory arrest, rescue breathing, important. Recovery position, laying them on that side, lateral recumbent position. O2 sats, keep them greater than 92%, intubate if apneic. When you get them to the ED, protect their airway, intubate if not done in the field or if they're apneic. B would be supplemental oxygen to keep sats 92 to 96%, can be done with BiPAP if they don't need to be intubated. C, not always affected, if so usually bradycardia, PEA, or asystole, that's cardiac, ABC, so we're on C, place on cardiac monitor, monitor their blood pressure, pulse ox, end-tidal CO2. In the ED, D, check their GCS, elevate the head of bed 30 degrees to help decrease their ICP. If seizures, give non-sedative anticonvulsives, Dilantin. E, remove the wet clothes and rewarm, core temps and monitoring rectal temperature. And they have also the Foley temps, temperature Foleys. Warm blankets, warm fluids, warmed humidified oxygen for hypothermic patients. So when they are hypothermic, we want to rewarm them slowly to keep them from having seizures and to keep them from vasoconstricting and a gamut of other issues. We're going to look at the history, get as much information as we can, the mechanism of injury, any comorbidities, drug or alcohol, and a suicide attempt. We're going to assess them neurologically, the whole body, neuro, cardiac, pulmonary, interventions, valve mask to intubate, BiPAP or CPAP. You may need an IV if you can't get one of those, an IO, or check their core temp, OGs or NGs to aspirate gastric contents to decompress their belly, chest x-rays, ABGs, CT of the head, CT of the chest, EKGs, urine drug screens. Most all non-fatal drownings are either observed for 8 hours in the ED or admitted for observation. Most non-fatal drowning victims are hospitalized because of the severity of illness or concern of clinical deterioration. Symptomatic patients should be admitted to a monitored setting until symptoms and physiological disturbances have resolved. EKGs, measurement of serum electrolytes and creatinine and serum and urine analysis for alcohol and illicit drugs are recommended. Then asymptomatic patients should be closely observed for approximately 8 hours and admitted if any deterioration signs occur. If vital signs, pulse ox, all studies, including chest x-ray or CTs obtained close to the end of the observation period are normal and no clinical deterioration develops. During this time, the patient may be discharged with appropriate follow-up care. Clear verbal and written instructions to return to the ED immediately for any respiratory or any other problems are given to the patient before they are discharged. Nursing priorities: airway, breathing, circulation. Airway, ventilating, 2 rescue breaths, then CPR. No Heimlich or postural drainage for these folks. Intubate if they're slowly breathing, low breathing, or no spontaneous respirations. Cervical spine cord injury is uncommon, but when thought or suspicious, then that has to be cleared first. Pulses may be difficult to palpate in a hypothermic patient. Careful pulse checks every minute. So it's kind of like having your fingers there while you're assessing the rest of your patient. Remove any wet clothing, replace with blankets for insulation, rewarm passively or invasive means. Aggressive resuscitation with warm fluids to overcome dehydration caused by cold diuresis, cardiac monitoring, invasive tip monitoring, CPR if necessary, continuous assessment, and monitoring. Keep SATs greater than 94%. Because of the neuroprotective effects of hypothermia, complete recovery of patients with hypothermia and cardiac arrest have been well documented despite prolonged resuscitation. Think about, I don't know if you all have heard this or discussed it yet, but the hypothermic protocols for the cardiac MI patients, where we cool them down and preserve what we can and then rewarm them in 24 hours. Different story, different lecture. Prognosis for these folks with drowning is going to depend on age, water temperature, duration of in the water, effectiveness of the rescue. Children under the age of 14 have had improved prognosis according to evidence-based studies because they're thought to be in better health. Cold water decreased neuro effects, but increased cardiac arrhythmias when rewarming. An initial GCS of less than 5 is poor prognosis. The duration of time in the water is poor prognosis if greater than 25 minutes of submersion. Fatality submersion is less than 5 minutes and 10% of fatals. And as the time of submersion goes up, also increases the amount of fatality for these folks. So depending on the amount of submersion time will depend on their fatality rate. Effectiveness of rescue, poor prognosis if rescue treatment took greater than 25 minutes to occur. So evidence-based research. Let's do prevention. Infants and toddlers, we're going to monitor them closely when they're in the water. We're not going to leave them alone. Supervise that bath time. Fences and locks around pools. Familiarization of the area. Remove their toys from the pools and the bathtub so they can't go head in first in the bathtub. Educate parents. Don't leave anybody, especially your small ones, in the bathroom by themselves. Let's start them in swim lessons. Learn to swim. Teach them what water is. Teach them what's around the water, the area. Never swim alone. Never, ever. Boating, safety, life jacket regulations. We need to know them. If you're in a boat or around the water, learn to swim. Learn CPR. Learn BLS. Feet first in the water, not head first. What happens when you go head first? You dive into an area of shallow and you break your neck. Pay attention to posted warning signs, such as the beach, unsafe swimming conditions. Don't allow children to swim in drainage ditches because what happens when it rains, the downpour and flash floods will happen quickly. Abandoned surface mines or other water-filled areas not intended for swimming. Don't go there. Beware of thin ice, especially this time of year. A couple of more videos. Pathophysiology of Drowning takes you through the 2 types that we talked about. Rescue drowning, what happens when there is a rescue. Drowning treatment, and patho is submersion or immersion. And I have questions, and these questions are going to be on your tickets. So because we can't be in person and I can't get feedback from you as often as I would like. So here we go. A lot of content. Reach out. Ms. Guyton is your emergency room specialist, and some of you have had emergency room where you work and that kind of thing. So if you have trouble with this content, please reach out. We'll get you what you need. Good evening. I'll see you later this week.